into this topic and to take you to real life scenarios, showing you what these little monsters can do. Let me connect this somewhere. I'm really proud to be part of our Zahra team now, because we have got a very dynamic, very young team, and we are providing 24/7 primary PCI care. What I have done today is there will be videos, there will be some interruption, I'm sorry if I'm struggling, and then at the end of each case and presentation there will be a take-home message, obviously. Now, my first case is a 53-year-old Afro-American with no history of chest pain. So what happened to him? He's usually very fit, no medical issues, but one day when he was at the gym, he collapsed while walking on the treadmill. So due to that collapse, he hurt his head, had a laceration. So he was visiting to one of my surgical colleagues, saying that, could you do something with this cut? And he said, fine, I can do something, but you need to go to a cardiologist. Why would you collapse on the treadmill? Anyway, he came to me. So if you have a look at this slide, it gives you a brief idea about causes of exercise-induced collapse. You know, a lot of people can collapse while running, jogging, climbing up the steps. So if you look at the differential diagnosis, on this side, you have abnormal brain activity due to various reasons, like epilepsy, hypoxia, hypoglycemia, hyperthermia. Okay? And then on this side, you've got abnormal arterial perfusion pressure. Now this is common. Then we can divide into three groups. Stroke volume, for reason the stroke volume is going down. So you've got pulmonary hypertension, pulmonary stenosis, dehydration, which is very common, hemorrhage, and then aortic stenosis, hypertrophic cardiomyopathy, and there is ischemia. Heart rate, you know, very fast heart rate, very irregular heart rate, atrial fibrillation, ventricular tachycardia, fibrillation, slow heartbeat, heart blocks. And then here you have got the peripheral resistance, when the blood vessels dilates and the blood pressure plunges. Now that's a snapshot, but obviously my interest is ischemia, and my interest is the sinister arrhythmias, ventricular tachycardia and ventricular fibrillation. And if you would like to find out why the patient has collapsed, it's very simple. History is the most important bit. Take the history carefully, do a clinical examination, ECG 24-hour Holter monitor, we do. Echocardiogram is very vital in this age group where we're talking about 50 plus. And then you can proceed to a CT coronary angiogram or coronary angiogram if you are too suspicious. But don't do stress tests on this patient. Remember, this patient collapsed while doing stress. So what did I do? I went straight to coronary angiogram after doing an echo. His echocardiogram was normal. Remember, this is a man who never experienced chest pain, not even on the treadmill before he collapsed. So I'm going to show you his angiogram now. So this is the left system, and as you can see, this is the catheter, the circumflex artery here. There is a bit of narrowing, and the OM branch. I'm not too worried about this narrowing here. It's got about 50% blockage. Circumflex doesn't cause collapse. There's something there in LAD which we will discover shortly. So as we move on, there we go. Now, can you see there? So this is the LAD giving off a diagonal branch, and there is a narrowing, and it's a huge LAD. We'll keep moving on. There it is. So this man has got significant disease in his LAD, almost proximal, just after the diagonal is mid-LAD, but pretty close. And look at there, if this man is exercising, and if there's a significant blockage, a huge myocardium will be affected. Okay? So there are two reasons for this man to collapse. Either ischemia causing sudden drop in blood pressure, or he might have had a brief episode of ventricular tachycardia. And this can cause death, obviously. So I had no options because he's a very active gentleman. I put a stent in. As you can see there, that is a narrowing bit. And this is what the angiogram looks like. You see the blockage was here, which is all open up. So that's his story. His risk factors, besides being 58 and male, his LDL was 6. Very high. Very high. I struggled to bring his cholesterol down, believe me. So, all exercise-induced collapses are not vasovagal in nature. This is the take-home message from this case. Case 2 is a 46-year-old Burmese gentleman, 46, relatively young. He presented to ER with chest pain. Blood pressure was highish, but he's not a known hypertensive. Gives history of impaired glucose tolerance, dyslipidemia, troponin was negative. Now my colleague who has left our hospital is a very good cardiologist. He did an echo in ER. We usually don't do echoes in ER. There was a reason. So he was discharged home on the following day after a negative second tropi. I made him walk on the treadmill. He could walk only 3 minutes, stopped because he was breathless, he was having chest pain, and the left ventricular outflow tract gradient was not significant. So it was a non-obstructive hypertrophic cardiomyopathy. So then I asked myself, when this man comes back again saying, Doctor, I'm not getting better with beta blockers, with all your medication, I'm not better. What to do next? I did an angiogram. I will tell you why I did an angiogram. So here we go. His angiogram. The circumflex looks very nice. Look at his LAD. And then all of a sudden, can you see that? How narrow? Initially I thought, is it myocardial bridging? Is it the compression of the myocardium? But no. This is almost 80% narrow in his mid-LAD. There. And I will show you another interesting thing. This is right coronary artery. Can you see that blob there? There? Yeah? This is an ulcer. An ulcer in a plaque. And these are very dangerous. This can cause MI anytime. Anyway, to cut the story short, this is his LV angiogram showing the concentric LVH. Did the angioplasty. It was a bit tricky because a diagonal branch was coming off there. So that's the result after angioplasty. There we go. There. So it was narrowed there. It's open up now. After PCI, he now can walk on the treadmill for 6 minutes. So his exercise capacity has increased from 3 minutes to 6 minutes. But now he is not having any more chest pain. Just let me briefly tell you about hypertrophic cardiomyopathy, where there is problem with abnormal protein in the heart muscle. That can cause fibrosis. Fibrosis is not a good thing, it's hard. And then there is muscle hypertrophy. And the other fascinating thing is the small vessel. They get negative remodeling. That means that smaller microvessels get even narrower, causing compression outside, inside, and then perfusion defect. Not only that, the capillary density also goes down, and eventually they suffer from ischemia. So what I have tried to explain you from this particular case is that coexistent atherosclerosis or coronary artery disease can be present in up to 25% patient with hypertrophic cardiomyopathy. It means someone may have a cardiac disease, but we should always remember that the patient may have coronary artery disease as well. We need to be very much cautious. Now this man is very happy because he can do more now. So that was my second case. Third case here is a 43-year-old Indian man with chest pain who loves smoking. Why I have said love smoking, you will soon know. I was reading a paper recently where it's been shown that smoking itself is the worst risk factor for cardiovascular disease. It's riskier than diabetes and dyslipidemia. Anyway, so relatively young man with no problem comes to hospital with ST elevation in inferior leads. So he had the usual stuff. Now this was happening in a different hospital which does not have angioplasty facility, but he was treated well there and he was transferred to our facility. Interestingly, when he comes to us, his ST segment have gone down and he doesn't have much pain. But obviously, we need to do a catheterization. Okay, so 43-year-old with inferior infarct, I thought he may have problem in his right coronary artery, but when I start doing the angiogram, this is what I found. This is left main stem, diffuse disease. There is a tight stenosis in his OM branch. He has got diffuse diseases and LAD. There it is in LAD. But his main culprit artery was the right coronary artery. So this is a man, a young man with 3 vessel disease. And the only risk factor, he didn't have family history, just smoking. He was smoking about 40 to 50 cigarettes a day. So quickly, I put a stent in OM branch. It looked fine. And then move into LAD. It went well, as you can see, it's open up. And I will show you next the right coronary artery, which was the culprit vessel. Here we go. So it was pretty tight, the right coronary artery. And he had a stent there as well. And this procedure took roughly less than an hour. So this man had equivalent to a bypass surgery, who loves smoking, and I thought he might have only one blockage. Now this is a typical example of multi-vessel coronary angioplasty. The next case I'm going to show you is slightly different, and it will give you some insight. So let me just briefly talk about multi-vessel coronary artery disease. 30 to 40% of acute MI patient may have multi-vessel coronary artery disease. And you know, when patient comes with heart attack, we try to open up the blocked artery first. That is our priority, and we call it culprit vessel. Like this man, where he had a blockage in the right coronary artery. But he had blockages in the other heart arteries as well. Now, in the guideline 2013, we were asked not to touch the culprit vessel. We were asked to do only the blocked blood vessel, not the other one, and we were told that it may be harmful. But things have changed since then. You know, you may hear stories, oh my God, my uncle had 3 angioplasty. Did he really need 3 stents? Yes, the answer is he might have required 3 stents. And this is the reason. So when we look at outcome, we call it MACE, major cardiac event, which consists of death due to all causes, MI, bypass surgery, and PCI. So there were two trials, PRAMI and culprit. They looked at stenting not only the culprit lesion, not only the blocked artery, but the other blocked artery on the same sitting, which I did in my previous patient. And interestingly, this one was published in 2013, and have a look. What they did, small number of patients, 234 and 231. 234 had preventative PCI, that means they had stenting of the blocked artery and they had stenting of the other arteries which were severe. And the other group, 231, had stenting on only the blocked artery, but the interventionist left the other blockages as it is. So if you look at this curve, this is months and this is patients without primary outcome. That means the lower it is, the worse was the outcome. So clearly, when patient did not have stenting to non-culprit artery, they had more MI, more bypass surgery, more deaths. So this study favors that if an interventionist has found multiple blockage, they should try to open it up on the same sitting or perhaps after 2-3 days time, depending on the risk of the patient. The culprit trial also showed that 55% reduction of heart attack, revascularization or death can be reduced by 55% by doing stenting, multiple stenting in acute MR setting. Right, now my number 4 case is again interesting one. This is a bit older gentleman, 62-year-old with chest pain, no comorbidities, but gives history of renal stones, ST elevation in inferior leads, creatinine was 118. Now I was told when I was doing this angiogram, so a person who had renal stone with slightly high creatinine are usually a high risk group patient. Let me show you the angiogram here on this gentleman. So this is the left side. Circumflex looks fine, but there's some haziness here. It's proximal LAD. I cannot be sure. Some haziness. It's not quite tight. As we move on, it becomes a bit obvious. Something is there. I don't know. There. But it didn't look that bad. Okay. And then this is the culprit vessel. The right coronary artery, can you see it's almost blocked? There is a thrombus sitting there. Can you see the bends? I cannot forget this case because it took me ages to do it, because it's very tortuous, a lot of angles, a lot of ways of negotiating with the lesion. But anyway, he had a stenting and he was fine. But what happened afterwards was kidney function. So that's the stent there. It was not a straightforward case. He had these tortuous blood vessels. His creatinine jumped from 118 to 176. Now this is bad news for me. People end up having dialysis. But again, he had this proximal LAD lesion, which was tight, and I have to do it as well. So I did it after a week by following this measure. So I'm talking about contrast-induced nephropathy. Anyone who has got abnormal kidney function, they may have kidney function deterioration with angioplasty or angiogram. So we are very much cautious about it. These are the risk factors. How we can prevent it? By just giving saline, IV fluid. Some people give sodium bicarbonate, oral acetylcysteine. I am not in favor of it because there is no benefit. Now this is a very interesting thing which has come up, October, only last month. And it says, again here, Dr. Tamimi was saying high dose of statin. Look, atorvastatin 18 mg was used in patient who has got renal impairment a day before and 3 days, up to 3 days. And along with it, trimetazidine, which is formerly known as vascular MR, you may have heard it, it's an anti-angiogenic therapy. A combination of these two prevents contrast-induced nephropathy. And it clearly tells us that statin is a wonderful drug. Believe me, there will be more and more indication of statin in the near future. If you ask me what is the best thing, it's hydration. And eventually, I did this complex, very proximal stenting of LAD. As you can see, the circumflex is coming here. The positioning of stenting is very important. On the right side is IVUS, we call it intravascular ultrasound. Okay, so we can see inside the blood vessel. This is a very important tool, and we had a successful proximal LAD stenting after 1 week. Now, this is a 73-year-old man. I did this case last week only. He has been having chest pain all day long. But at the end in the evening, he was so unwell that he came to hospital with cardiogenic shock. In the evening, he came along, and that was his ECG. As you can see, ST depression everywhere and bit of key wave in the inferior leads. And I told myself, I'm in trouble, because I know he may have a cardiac arrest anytime. So quickly, very short thing, this is his right coronary artery, is blocked, 100% blocked. And you will see that it's filling there lately, and this is the left system, which is also blocked. So we are dealing with all three arteries are blocked, and this man was surviving by a collateral. Now look at that, this is his left main stem, it's almost blocked. So we started him inotrope from ER, we didn't waste time, we took him to cath lab, and I wanted to do only one thing, I wanted to put only one stent here. I was not bothered about the other two blocked arteries. So, if you keep looking at there, this is the left main stem, LAD, his circumflex is blocked. The balloon is going up, his blood pressure dropped to almost 0. And this is after stenting. As you can see, this is the left main stem, LAD. He survived. Okay, he was sent home on 5th day. His ejection fraction was only 25%. He didn't develop florid pulmonary edema. BNP, as you know, this is a marker for heart failure. In a 73-year-old, I would say 800 is the cutoff. It was 3,200, came down to 1,400. I saw him yesterday. He's now walking 30 minutes every day, and he's desperate to go back to Italy. And I think he's going within 2 days' time. So, very quickly, PCI and cardiogenic shock is a dangerous thing. 50% of them die while they're in the hospital. High mortality. We can give them inotropic support. There are 2 devices called inserted balloon pump, impeller devices. I'm not going to talk to you about them. These are the devices. Basically, they are artificial pump. Unfortunately, we're very much optimistic, even last year, that this is lifesaver. But unfortunately, none of these devices have shown any mortality benefit. So the only thing we can do is open the artery fast. So that's why we keep telling, if you have chest pain, come to hospital quickly. Let us open the artery quickly. Only 2 more left now. This is interesting. 78-year-old, okay, Chinese lady, only high blood pressure, visiting son in Dubai. She came to ER with chest pain, and within 5 minutes she developed VF. And we started doing CPR. We shocked her almost 18 times. Remember, VF is a treatable thing. We cannot stop. Her pupil was almost dilated. My registrar was telling me, Dr. Sakib, stop. And I said, I cannot stop. This is a treatable condition. I have to keep shocking her. After the 18th shock, we had a pulse, we had a blood pressure. We took her immediately to the cath lab. as expected, it was an LED lesion. Her right coronary artery was fine. Circumflex looks okay. And this is why she was having cardiac arrest. Her LAD was blocked, mid-LAD. So that's the balloon. She had the stent. Interestingly, there was another block downstream. I thought I'm not going to put a stent in, but believe me, her ST was still elevated, so I have to put another stent there. And she survived. She has gone back to China. Now, primary PCI in elderly population, we think elderly people, they won't do good with PCI, but believe me, they do wonders. Now, this is a small study from London, Harefield Hospital, and as you can see, this is the intervention arm, and with primary PCI, this is the survival rate, 86% at 1 month, 6 months, and 12 months. Good survival rate. But here you look, in conservative arm with no PCI, the survival rate is almost half. So by doing PCI in elderly group, you are increasing the chance of survival. This is my last case and it's very fascinating. 45-year-old Caucasian, in fact he's from England. He came with chest pain. He was on holiday with his family. He developed chest pain and he gave history of having pulmonary embolism. That's why he takes this injection Flexane every time he flies. Non-smoker. So 2 hours history of breathlessness and chest pain. Have a look at the ECG. He's in ER. The ER doctor called me and said, Dr. Sakib, this man is having anterior ST elevation. It's an MI, please come. So I came along. I explained him briefly. He's still having chest pain. Obviously, I have to take the consent. I explained him the risk and benefit. And when I was about to take his consent, he went into VF arrest. Okay? We start doing CPR. Now, again like the last lady, he was having shock after shock. And I said, I cannot take chance. I want this man in the cath lab. So what we did, this is not us, but to show you, this is a CPR device. You might have, oh no, it's not running. It's a device which automatically gives you compression. Okay? So we put the pads on, we put this device on, and we were basically doing CPR on transit. We took him to the cath lab and start doing this angiogram. Now look carefully. When I say carefully, what if I say I didn't see much of blockage anywhere? There was some disease in his LAD, definitely, but no significant blockage for me to do stenting, right? There's some disease there, narrowing, but no blockage for me to do stenting. This is the right coronary artery, looks fine. And by now, his ST has come down, and I was wondering what to do. He had a cardiac arrest, anterior infarct, his ST is coming down, where should I put stent? You know, look at the ECG. This was taken while he was on the table. Do you see the ST has come down? So I said, look, the blood pressure has come up, ECG looks better. Why should I poke anymore? I stop. I think one of the greatest things which my mentor taught me is that, Sakib, always remember when to stop. Because if you don't stop in the right time, you may harm the patient. So I thought, I'm going to stop here. So, this man was extubated after 48 hours. His echo showed ejection fraction of 30% only. He had anterior septal wall hypokinesis, confirming that he had a heart attack. And I put him on all this medication. Follow-up after 1 week, he was doing well, and he flew back home to England after 10 days. And I told him, please keep in touch with me because you would require more tests to find out exactly what happened that day. He had a heart attack, and I knew he had a thrombus somewhere which got dislodged with the heavy compression of the machine, and there was nothing left for me to do. So, he had a repeat angiogram in England, which was normal, so-called normal. So they did a thing called OCT. It is again like a camera which goes inside and looks blood vessels from inside, and it did show some atheroma, some atherosclerosis in proximal LAD, and then he had a cardiac MR which confirmed scarring in the anterior wall, suggesting that he did have a heart attack. And would you believe his ejection fraction has come back to normal now? So what he had was a part of Minoka. Now what is Minoka? Myocardial infarction with non-obstructive coronary artery disease. So when you do an angiogram, you may not see any obstruction anywhere. It may be almost normal when you're looking at the angiogram, but there is a problem. So what kind of problem they are? Now remember, these group will have heart attack, but the mechanism varies. So they will come with chest pain, there will be ST changes, there will be perfusion problem, there will be LV dysfunction as we showed on echo. But they will have either no obstruction or less than 50% obstruction. You see, we never put stent in 50% obstruction. We usually put stent if it's around 70%. So this man had a Minoka. Let's have a look. The mechanism epicardial causes, the LAD, the circumflex, the right coronary artery, they can go into spasm. It can happen very rarely. I haven't seen in my life. There was only 1 or 2 cases, cocaine abuse, heavy smoking. Eccentric plaque. Now this is the thing. If you look at the lumen, and if the plaque is eccentric, just in one corner, when you're doing angiogram, it will not show up. Okay, this is what we often miss on coronary angiogram. And this is what the man had. He had a plaque, and it was not visible on angiogram, and he had thrombus, and possibly because of the heavy compression of that machine, the thrombus got dislodged, and I didn't see anything. There is this interesting syndrome called Takasubos, which I have seen only 5 in my lifetime: microvascular spasm, myocarditis, coronary embolism. So these are the causes. When you do an angiogram, patient had heart attack, but the angiogram is normal or near normal. And this is what we call intravascular ultrasound. This is equivalent to endoscopy. We call it angioscopy. So you're looking inside the heart artery. This is the plaque, as you can see. On the angiogram, you don't see much there, but when you look from inside, there's a big plaque sitting there, and it has ruptured here. This is the lumen. Same here, this is the OCT, which my patient had in England. This is a hematoma. Look, this is the lumen, which has become so small. So take home message. Is angiogram is the gold standard? The answer is no. Normal angiogram is not anymore a right comment. Near normal angiogram is more acceptable. When I asked my patient, when you had this angiogram 7 years ago, what was it like? He said, doctor, it was normal. But when you see the report, you will find out he had atheroma there, he had atheroma there. Remember, angiogram is not angioscopy. We are not seeing from inside, we are seeing from outside. Myocardial infarction can happen even in patients with insignificant atherosclerosis disease. So one should not have 80% blockage to have MI. Last but not the least, acute coronary syndrome is a dynamic process. Thank you very much.
So let's go to the third presentation directly. I think no questions here. I'd like to introduce for you
One question.
one here. Question. Okay. Yeah, sure.
One question.
In the exam, one of the examples what you have mentioned about that, the patient, 70 years old lady, who came with almost cardiac arrest.
Yes.
Do you have an IIT in your brain too?
I have, yes.
Then why you did not think about IIT putting in IIT immediately?
Right. I am not a believer of IIT, I'm sorry to say this. I go by evidence. Shock 1, Shock 2 trial clearly says there is no benefit. I believe in opening the artery quickly. Okay, now that lady, she was also in cardiac shock, but she was maintaining her blood pressure. She had a systolic about 80, 85. If you have put an intratic balloon pump, you know how cumbersome it is. It's a big balloon. It has got its own problem. It can cause, what should I say called? Trauma, bleeding. So if studies are telling me that they are not helpful, why should I waste my time putting the balloon? Remember, it will take minimum 15 minutes to put the balloon in. I would prefer to waste that 15 minutes to open the artery to get a result. So that's why I didn't use the intratic balloon pump.
Any more questions?
Yes, I just want to increase my knowledge regarding the first scenario. That patient was some disease that could collapse.
Collapse,
on
yes.
the treadmill.
Yes.
And he is not having any prior history of the chest pain.
Yes.
And after that, in the evaluation of that patient, how we come to know, I am an internal medicine specialist, how we come to know there are so many, you show us in your slide, there are so many classifications of
Yes.
the reasons of the dizziness and
Yes.
all these things.
Yes.
So first, as a specialist in internal medicine, the first thing which comes in my mind, there must be some arrhythmia or something like that.
Sure.
So, should we go directly for the angiography, or we like interpret something like by use of the calcium scoring and something like that?
Yeah.
Calcium scoring or the CT angiography rather than the basic procedure for that person.
Very interesting question. Madam, I told you the most important thing is history. You know, you take the history, you look at the patient. I've got a 53-year-old man with an LDL of 6, has got nothing. So whatever he has got has to be something serious. His echo was normal, his ECG was normal. There was no history of palpitation, no dizziness, first episode, right? So I knew I'm dealing with something serious, something sinister. I could have done a CT angiogram, but the problem, it's not a problem. If you look at the guideline, if you look at the European guideline, they categorize low risk, intermediate risk, high risk group of patient. Okay? Now this man does not fall into high risk group. He's not in low risk group. He's in intermediate group. Very ideal for CT angiogram. But my problem is CT angiogram cannot quantify the blockage. So if I do an angiogram, I would see some blockage. Then I will scratch my head. Is it tight? Is it flow limiting? Is it really significant? Is it stentable? These questions will not be answered by CT angiogram. The only way to reach to a decision is by doing an invasive test. And that's why I avoided the CT angiogram. Absolutely, you have to go there, you know, more money for the insurers, radiation, and you want a quick result. That was a very interesting question. Thank you. Thank you very much.
Thank you.